This recorded lecture will be going over Chapter 9, Chronic Illness and Rehabilitation, in the MedSurg textbook. According to the CDC, nearly half of all adults are diagnosed with one or more chronic health conditions. Many of these can cause short-term or long-term disability. Patients with chronic illnesses and disabilities are cared for in a wide variety of practice settings. As an LPN, you may have the opportunity to care for patients in long-term care facilities, rehabilitation facilities, outpatient clinics, primary care settings, and even at home. The terms chronic disease and chronic illness are often used interchangeably by healthcare practitioners. However, they are quite different. By chronic, we usually mean lasting longer than 3 months. Chronic disease will typically refer to the pathophysiologic process that leads to the medical diagnosis. Diabetes, hypertension, heart disease, cancer, neurologic disorders, asthma, and musculoskeletal deformities are common chronic diseases. The term chronic illness, on the other hand, is broad and refers to the lived experience of the patient with the chronic disease as well as their family. A disability is linked to a person who has a condition or quality that is present when common activities such as walking, talking, reading, or learning are restricted. Some disabilities, such as blindness or hearing loss, are apparent to others, whereas some, such as chronic depression, are not. The term impairment refers to the dysfunction of a specific organ or body system. In the past, the term handicap was used to describe patients with chronic illness. This term is no longer acceptable as a description of an individual. However, it can be used to describe an obstacle imposed on an individual by some limit in the environment. When chronic illness causes the loss of function, usual roles can be changed. Changes in the person's role will affect the family as well. Daily patterns are altered to accommodate treatments and therapy and to cope with the problems of their disability. Spiritual distress can be experienced as the person is faced with limitations of their illness or disability that has occurred. Patients with a chronic illness and their families might feel powerless, especially during the phases of diagnosis and early treatment. Support for the patient's usual coping techniques and teaching new ways to cope will help the patient effectively deal with their illness as well as any changes in their life patterns that it will bring. Be instrumental in instilling hope and a good quality of life, as well as fostering resilience despite an illness. Patients experience decreases in mobility for varying degrees and for different amounts of time. Patients who have any disorder requiring bed rest are at risk of immobility. All of these patients are subject to problems of decreased mobility. Evaluate each patient's situation and determine whether the patient is at risk for problems related to decreased mobility. Even if the patient is going to be immobile for just a few days, measures need to be taken to prevent any secondary problems. Patients with disorders causing decreased mobility need to be assessed for their degree of risk for various associated problems, and interventions to prevent them must be initiated. Early effects of decreased mobility would include a decrease in muscle strength, generalized weakness, easy fatigue, joint stiffness, decreased coordination, abdominal distension, risk for VTE, and various metabolic changes detectable by laboratory testing. The prevention of problems related to decreased mobility begins the moment a patient first becomes ill or injured. Lack of mobility can begin a cycle that leads to an ever-increasing loss of independence for the patient. As the nurse, you can reduce that risk by helping the patient maintain functioning of each body system to the highest degree possible. On page 184, take a look at the 2 red boxes with the older adult care points. Although many older adults are active in their daily lives, some older adults may not be able to engage in regular physical activity. When their mobility is decreased, muscle strength and flexibility are diminished due to disuse. It is much more difficult for these patients to regain their mobility. Assess the patient daily, looking closely at each body system in which a problem related to decreased mobility might occur. It is important to recognize signs and symptoms of each type of problem and to understand how to intervene to decrease or prevent it. The assessment details and nursing care for each problem are discussed in this chapter. Older adults are at a greatly increased risk for problems of decreased mobility due to the changes in their various body systems that will normally occur with aging. We need to monitor them closely for any pressure sores, as well as hypostatic pneumonia, constipation, urinary problems, and inadequate nutritional intake resulting to lack of appetite. Attention to range of motion exercises is also very important and can often go neglected. Rehabilitation may be required for patients who are experiencing debilitation from a chronic illness or who have experienced complications from an acute illness or a traumatic accident. Many older adults who have several chronic problems and deficits in self-care will enter long-term care facilities for the remainder of their lives. Some patients are discharged home to continue with rehab services in the home or outpatient. RN supervisors will typically manage care for an entire long-term care facility on a 24-hour basis and then delegate tasks to the LPN. An LPN will often assume the role of charge nurse, and CNAs, patient care assistants, or restorative aides will provide much of the direct basic care to the residents. Although the RN ultimately is responsible for the nursing care plan for each resident, the LPN charge nurse will make significant contributions to patient care. Collaboration with the RN is essential to ensure that the plan is appropriate and complete. Appropriate delegation is vital to your role as an LPN. You may assign specific tasks to the patient care assistants. A good understanding of how the patient care is delivered is important as you delegate these tasks. Patient care assistants are often the main direct caregivers in the long-term care facility. It will be important for you to establish rapport and show respect by appreciating their contributions, as well as listening to their concerns, as they are vital to the overall welfare of the patient. When planning care for residents in a long-term care facility, the LPN needs to keep in mind that the overall goals of care for the facility are to provide a safe environment, to assist the resident in maintaining or attaining as much function as possible, and to promote individual independence, as well as allowing the resident to maintain or achieve as much autonomy as possible. Providing a safe environment for a group of residents, some of whom may be cognitively impaired, while allowing autonomy and independence, is a great challenge. Two of the greatest safety concerns are to keep confused residents within the boundaries of the facility and to prevent falls. The first step in the prevention of falls is to recognize which residents are at the greatest risk. All residents are assessed for the risk of fall upon admission and whenever their condition changes. The next step to preventing a fall is to recognize hazards in the environment that could precipitate a fall. Restorative programs will focus on muscle strengthening and balance. Residents at risk for orthostatic hypotension position should be taught ways to decrease their risk of falling. A resident who is receiving diuretic therapy needs to be assessed frequently for fluid and electrolyte imbalances that can cause weakness, dizziness, or confusion. Residents on diuretic therapy should receive prompt assistance for toileting whenever their assistance is requested. The bed needs to be kept in a low position. Take a look at box 9.5, Interventions to Help Prevent Falls, on page 189. A gait belt can be very helpful in preventing falls. It's important to remove loose rugs or secure with a non-slip pad. Keep wheels on all equipment locked when stationary. Provide chairs that are the proper height and depth to prevent any falling into the chair or leaning far forward to arise from the chair. Choose a chair with sturdy arms to aid in rising. Also take a look on page 189 at the red safety alert box for the medication assessment. Assess all medications a resident is taking to determine the risk of medication-induced postural hypotension or dizziness. This can contribute to falls. Don't forget to include over-the-counter and herbal medications, as well as prescription medications, especially diuretics. When a resident frequently forgets instructions to call for assistance, repeatedly attempts to get up and falls, or interferes with medical treatment by pulling out their ordered tubes or scratching at wounds, the use of security devices might be necessary. However, these devices should be used only when all else has failed. Research has provided strong evidence that restraints will actually increase rather than decrease the patient's risk of injury. Physical and chemical restraint use is restricted by law and can only be applied as a last resort for safety when a resident is exhibiting a threat to themselves or others. The purpose of these statutes is to ensure that restraints are not used to ensure that the restraints are used to protect the residents and not to hinder any movements for the staff's convenience. Alternative measures always need to be tried first. All security devices need to be used only as a last resort, and they must be ordered by a healthcare provider. If a qualified licensed nurse determines the need for a chemical or physical security device in an emergency, the need must be specifically documented when the security device is applied. A provider's order for that security device needs to be written every 24 to 48 hours. A resident who is immobilized with a security device needs to be checked visually at least every 30 minutes to ensure that the resident's body is in good alignment and there are no problems. These checks need to be documented. Whenever you are in the patient's room, check their skin color for circulation in any affected body parts. Residents do need to be turned or repositioned every 2 hours. Thorough assessment of skin and circulation should be done at that time. The restraint should be removed immediately after the risk has been reduced. Always make sure the resident has access to their eyeglasses and hearing aids to reduce their sensory deficits. Adequate rest, sleep, fluids, elimination, pain control, and comfort measures are all recommended by the Hartford Institute for Geriatric Nursing. Environmental aids such as readable, up-to-date calendar, a clock, and a daily newspaper or local television or radio news show can help. Remember that the priority is to maintain a safe environment. Consistency in meal times, scheduled activities, treatments, and daily personal care routine can also be helpful. Do not overwhelm the resident with options, but instead allow them to choose their preferences during activities. Family members can be particularly helpful here. A time schedule for activities and events within the facility should be posted in large print where the resident can refer to it frequently. Decorations for the next upcoming holiday can give clues to a current holiday season. A positive and helpful approach is to respond continuously to the resident's confusion with honest and real information. Remember to assess the possibility of a physical cause for the confusion, such as a urinary tract infection, constipation, dehydration, reduced oxygenation, or suboptimal pain control whenever there is a change in the resident's usual ability to interact. Late afternoon or evening confusion, often referred to as sundowning syndrome, can occur in some older adult residents. Residents most at risk for this are those with cognitive impairment, as well as those who may have a decreased ability to compensate for fatigue or stresses after a long day. Other factors that contribute to sundown syndrome included those that can disrupt the resident's normal routine, such as room changes, changes in a roommate, changes in routine, decreased engagement in social activities, and social isolation. Interventions that have been effective in reducing sundown syndrome would include activities such as group singing in the late afternoon hours, increasing the amount of daytime lighting between 7 a.m. and 9 p.m., and specialized training of nursing assistants. Other strategies can include keeping the call bell within reach and visiting the resident frequently to calm and reassure them. A bed alarm can alert staff to when the resident attempts to get out of bed. Keeping the resident active during the day and encouraging physical exercise will help promote sleep at night. Listening to the resident try and determine any possible cause of unrest or fear will often help solve the problem. The move to a long-term care facility is a major upheaval, particularly when it is for the remainder of a person's lifetime. Specific goals should be set with the resident to encourage independence in activities of daily living and in recreational activities. To promote a resident's independence, staff members should refrain from doing tasks that the resident is capable of doing himself. If the resident is ambulatory, exercise should be planned and encouraged on a daily basis. If the resident is not ambulatory, range of motion exercises should be performed several times a day. Measures to promote continued bowel and bladder continence are essential. Mental stimulation is essential to maintaining a high level of cognitive functioning. Scientific shows, travel shows, public TV specials, and similar programs can stimulate thinking and encourage the sharing of thoughts on a variety of subjects. Card games can promote mental stimulation as well as social interaction. Continuing interest in lifelong activities is a factor in successful aging for many. Documentation in a long-term care facility is somewhat different from documentation in the hospital or home care setting. Rehabilitation is the process whereby a disabled person is helped to achieve an optimal level of functioning. A primary goal of rehabilitation is to minimize the deficit from the condition and maximize the abilities that are intact. It involves measures to achieve the highest possible levels of physical, emotional, psychological, and social functioning. Rehabilitation is concerned with achieving a better quality of life. The goals of rehab are to, number 1, promote new coping skills. Number 2, teach adaptive living skills. Number 3, focus on self-care and increase independence. And number 4, to improve the quality of life. Most patients who require rehabilitation services are disabled as a result of a chronic illness. Others have become disabled due to trauma incurred during an accident. Stroke is the most common cause of paralysis and spinal cord injury. Multiple sclerosis and cerebral palsy will round out the top 4. Several of the objectives for Healthy People 2030 are rehabilitation oriented. These would include objectives directed towards improving access to programs, increasing access to social and emotional support services, and improving access to interventions in the home and community-based settings. Rehabilitation services are offered in freestanding rehab hospitals, in general hospitals, and in skilled nursing homes, where the patients will stay for a few weeks. Rehabilitation programs have a philosophy that is based on 3 beliefs. Each person is unique and whole within themselves, and they are interdependent with their own environment. Independence can be achieved within the limits of disability when a person is a full participant in managing their own life. The goal is to enable patients to mobilize their own resources, choose goals, and attain those goals through their own efforts. Take a look at the older adult care points on page 193. An older adult patient who has suffered a major loss of body function may not be initially receptive to rehabilitation efforts. It will take a skillful nurse to help motivate the patient to want to improve their functional ability. Sometimes introducing the patient to someone close to their own age who has been through a similar illness and managed to regain some of their functions is the best medicine. Gentle encouragement with praise for small efforts and accomplishments is better than trying to force the patients to perform exercises or practice tasks. A pulmonary or respiratory rehabilitation program will teach the patient self-care techniques that can help them attain a better quality of life. There are generally 3 components to a PR program. This includes breathing exercises, paced walking exercise, and correct use of inhaled medications. Teaching the patient how to avoid respiratory infections is also enforced. Cardiac rehabilitation programs are usually outpatient-based and consist of several components, such as monitored exercise to increase their strength and endurance and build collateral circulation to the heart, diet counseling and education designed to lower cholesterol, triglycerides, and body fat, medication counseling regarding the purpose, administration, and side effects of their prescribed medications, vital sign monitoring to determine the effect of exercise on the cardiovascular system, group sessions on stress reduction techniques, and support group sessions for those experiencing depression or anxiety after surgery or an MI. Due to insurance limitations, patient treatment is not always possible. Rehabilitation efforts will then need to be continued at home. Nurses who work with rehabilitation patients need to be flexible and creative. Providing patient-centered care is essential. This means that the patient is not only the focus of the rehabilitation team, but also a member of the team. Your function is to assist the patient to achieve an optimal state of wellness as defined by the patient. Besides the healthcare provider, occupational, physical, speech, cognitive, and recreational therapists, vocational counselors, and social workers will also be a part of the team. A collaborative or interdisciplinary care plan is followed so that each member of the team is aware of what treatment and education the patient is receiving. Both short and long-term goals must be set. Team conferences are scheduled regularly so that members can collaborate on the patient's care and evaluate any rehabilitation progress. The patient and family will undergo considerable stress during the rehabilitation period. Caregivers need to assist the patient and family in developing positive coping techniques. The philosophy of rehabilitation nursing is based on the recognition of the patient's need for independence. Learn to judge when the patient should be allowed to struggle to do something on their own, and learn to recognize when the patient's frustration is reaching a level to which assistance is needed. Often 2 levels of LPNs are used in rehabilitation facilities, depending on the individual State Practice Act and facility protocols. One level is the LPN and the other level is the LPN 1 and the other level is the LPN 2 with IV therapy and functional independence measure certification. The LPN 1 does all nursing activities except assessments and IV infusion therapy. The LPN 2 performs the same functions as the LPN 1 in addition to tasks involved with IV infusions. The LPN is an active participant and facilitator of structured and non-structured learning experiences. After obtaining a thorough history, a physical and psychosocial assessment needs to be performed for each patient in order to establish a baseline to determine physical limitations, their ability to perform ADLs, and any amount of assistance that they require, as well as to identify and present any psychosocial difficulties. A skin risk assessment and fall risk assessment must be performed. The patient's home environment is examined before discharge to determine whether any physical features of the home, such as stairs, narrow doorways, or access to the bathroom, will present a problem. The patient's usual daily schedule and habits of everyday living are examined. This includes sleeping, waking, eating, elimination patterns, hygiene, grooming, sexual activity, working, and leisure activities. A functional assessment of how the person's disability has affected their former usual patterns will focus on the patient's present ability to perform their ADLs, such as toileting, bathing, dressing, grooming, and ambulating, as well as their ability to use the telephone, shop, prepare food, and perform household chores. Use of defense mechanisms, level of anxiety, and usual coping techniques are explored. To ascertain the patient's response to loss, ask them to describe their feelings related to the loss of a body part or body function. Patients with life-changing illness or injury, those who have suffered major loss of body function or former roles, and those who have lost most of their independence and social contacts can suffer from anger management and depression. Assessing their mental outlook is an ongoing nursing function. The patient needs to be kept safe, and determining suicide potential in the depressed patient is a priority. Sexual concerns need to be addressed during the rehabilitation period, and if you are not comfortable or knowledgeable in this role, do not hesitate to contact another member of the healthcare team. Periodic care conferences are essential for the members of the healthcare team to evaluate the progress of the patient, to share perceptions and ideas, and to revise the plan of care if it is not helping the patient meet their expected outcomes. In some settings, these conferences can occur several times a week. Others may occur maybe once every 1 or 2 weeks, or even once a month. During the conference, both long-term and short-term goals will be determined. Interventions are carried out in a manner that encourages patients to do as much for themselves as possible. Patients receiving rehabilitation interventions may be working with a physical and occupational therapist, speech therapist, and recreational therapist. Speech therapists and activity therapists will be involved in the implementation of the care plan. Discharge planning is implemented from the time the patient enters the rehabilitation. Most care in the community setting is given by home health and/or hospice agencies. Home health care is the preferred and most cost-effective method of healthcare delivery. The goal of home care is to keep the patient as well and as independent as possible, and to enable them to live at home. The LPN needs to have 1 year of experience working in an acute care facility before they can work in home care in most states. For home care, the RN will act as the case manager and coordinate the care of all the healthcare providers involved in that patient's care. Home care nursing can prevent a patient's expensive readmission to a hospital or entry into a long-term care facility. Home health care is family-centered, and the family members are also responsible for the ongoing care of the patient. Home visits are made to intervene and to see that the patient is provided comfort, to see that complications are being prevented, and that health has improved, as well as to assist with rehabilitation. Your philosophy must have a different focus because home health care is family-centered. In the home health care setting, the patient and family are in charge. You are a guest in their home and you act as a consultant, coordinator of care, provider of skilled care, teacher, and advocate. Together, you and the patient and family will set goals for care, and then you will establish the boundaries of your role. Be sensitive to a patient and family's cultural values, financial resources, and specific ways of doing things, and try not to impose your own views. A home care nurse must be very flexible and creative in teaching patients with families ways to accomplish care of the patient while abiding by the principles of asepsis and safety. Hospice care can be delivered in the home, long-term care facility, or the hospital. Hospice and palliative care is now available to children and adults with chronic illnesses, with a focus on supportive care at the end of life. A large percentage of the home care nurse's time with the patient is spent evaluating physical and psychosocial status, signs of complications, side effects of medications, and effects of therapy. Each visit will include a physical assessment of the identified problems and of nutritional, home safety, elimination, skin, and psychosocial status. The patient and family can contact the agency or you at any time, and these phone calls are encouraged. Other functions of the home health nurse would include performing wound care and dressing changes, organizing medications for scheduled administration, monitoring blood sugar levels, drawing blood samples for laboratory testing, giving injections or teaching injection technique, monitoring pain control, and monitoring enteral feedings. The home care nurse needs to be a strong advocate for the patient's needs and treatment. The home care nurse will provide considerable psychosocial care for the patient and family. A full knowledge of community resources available to the patient is essential. The hospital nurse will stay out of financial concerns, except to provide referrals to the social worker, but they must try to help the patient find remedies to their financial problems so that their stress can be reduced and energies can be directed at healing and techniques of self-care. LPNs working in home care are typically under the supervision of an RN case manager. The role of the LPN in the home care setting is growing. Nursing care plans are formulated considering 24-hour needs in collaboration with the patient, family, relatives, and other healthcare providers. Case conferences are conducted regularly, even if the case manager does them on the telephone with the other people involved in the patient's care. Medicare requires that a case conference be performed every 60 days when one or more discipline is involved in a patient's care. When a patient has a considerable disability and cannot function independently, a family member will often become the main caregiver. The caregiver's usual life is disrupted, and social contacts are limited due to the time constraints and fatigue. You must assess the caregiver's stress level regularly. When caregiver stress is high, calling an agency social worker for consultation can provide either more help for the caregiver or a respite program that might provide the caregiver with a few days of needed rest and relaxation. A respite program will provide room, meals, and care for a patient while the caregiver is relieved of all responsibility.